Good afternoon. I will speak about not uncommon problem in which I have recently published a paper on the Middle East Journal of Ophthalmology. As you know, thyroid patient, usually young patient and unhappy because their life is being ruined cosmetically after loss of vision from compressive optic neuropathy or corneal exposure. Diplopia is the one of the most problematic aspects, difficult to treat. Here are some clues how to do it and pitfalls of doing it. Strabismus is an important element of the disease which commonly impacts on the patient's quality of life. The unstable ocular misalignment results in symptomatic double vision, which is difficult to manage. Thyroid patients often are young and have background of the orbital treatment, such as this patient. He looks terrified with his cosmetic appearance as well as double vision. Patients may avoid diplopia by adopting a compensatory head posture or by wearing patches, you have to ask your patient if he is a smoker to stop smoking, because the smoking is one of the most important factors get their symptoms worse. The tendency to misalignment in the resting position is counteracted by the patient's fusional range, which increases with time. As you know, the normal vertical fusional range is 4 prism diopter. As this woman, she has left hypotropia of 25 prism diopter, but she is able to look straight in the primary position because the large fusional range. An injection which has a spectacular effect to paralyze the muscle, but it's not likely used in thyroid patients. Process ongoing, we look for 6 months of stability. We reviewed retrospectively the hospital record of all patients with thyroid strabismus undergoing strabismus surgery under Pediatric Ophthalmology at the University of British Columbia, Vancouver, we found 143 patients. 80% of them represent a success rate after single surgery for the horizontal deviation, but only 66% for the vertical one. Why is that? I will explain it in the coming slides. Prior to operation, we need to define and document the movement. At each visit, the patient should undergo an orthoptic evaluation with his chart, documentation, and prism cover test measurements in all gaze positions in the distance and near reading positions. The field of binocular single vision with a scoring is very important to graphically demonstrate for the patients the current limitation as well as the expectation post-operatively. CT scan and MRI are useful to help to determine which muscles are involved as well as to what extent. This is the proper orthoptic workup we should have in our clinic. The orthoptic report is sum of the balance of forces acting on both eyes. So this patient, as you see here, he has left hypotropia when fixing the right eye and marked restriction of elevation. He secondary to thyroid orbitopathy. We can't tell exactly what's going on, but we need to measure the intraocular pressure and up gaze. If there is restriction, it will be increased. This is how the people think of the eye movement. It's up, down, in, out. But this is not how the strabismus surgeon thinks of the eye movement. This is how strabismus surgeon looks to the eyes as yoke pair. So in the left gaze, it represents the right medial rectus and the left lateral rectus, while in down and left, it represents the right superior oblique and the left inferior rectus. As in patients with the fourth nerve palsy, they will be unable to look down and in. This lady has double vision secondary to her thyroid problem with left upper lid retraction, and she has left hypertropia and trouble with her diplopia except an extreme face turn to left. This is her this is her eyes movement, which showed here her eyes well aligned in the right gaze, and she has left hypertropia of the left eye, and which increases in the left gaze and in down gaze. And this represents the left superior rectus involvement. Her orthoptic workup showed similar finding, left hypertropia in primary and down gaze and in the left gaze. We did for her CT scan to confirm that her left superior rectus involved, but potentially all her muscles are involved. You can see even the right orbit, she has fat medial rectus as well. So the force duction test is very important and the main key to determine which muscle, and in addition to measuring the intraocular pressure in up gaze. You need to explain very clear your expectations from surgery and what is your goals. Patients need to understand that the success rate of horizontal is more than vertical, and you need to list the complication, especially residual diplopia, or they will have a new diplopia in eccentric gaze, and discuss with the patient the anticipated progress. The post-op expectation, really you want to talk about the single vision in primary position and down gaze as your main goal post-surgery, because usually our patients, they think they will have brand new eyes post-operatively and they will see single everywhere, which is impossible. You can see here the little diagram. This is the binocular single vision with a scoring, as you see here. In the primary gaze, they give 3 marks. In down gaze is 3 marks, and the rest in up gaze and eccentric is only 1 mark. So your aim always to have single vision in the functional area. So you have to warn of the residual double vision in eccentric gaze, or he will have a new double vision. Largely, your surgery should be recession. A lot of problems in thyroid surgery rely to inferior rectus. Why it's such a complex muscle? It's because either short arc contact with the globe, or related to the inferior oblique and the ligaments, and the involvement to lower lid retractors fibers. What is the action of the inferior rectus? As you know, the inferior rectus is the muscle of reading. So mainly it is depressor, adductor, and excyclotortor. Sometimes surgery on the inferior rectus is unavoidable, such as thyroid patients. So regarding torsion, don't be surprised if your patient preoperatively has excyclotorsion because the inferior rectus is tight, but postoperatively the patient will have encyclotorsion. And don't be surprised if your patient undergo bilateral large inferior rectus recession, then he will develop a pattern postoperatively because the inferior rectus recessed. So this will recruit the superior oblique, which is encyclotortor and abductor. So that's why the patient postoperatively will have a pattern. You have to warn the patient prior to surgery about that. The patient postoperatively, he can't read, either because you did large inferior rectus recession, which induced a pattern, as I mentioned before, or the patient had medial rectus recession bilaterally, which caused inadvertent convergence insufficiency. How to avoid that? Either by reduce the inferior rectus recession with doing contralateral superior rectus recession, or by doing medial transposition of inferior rectus. Some people, when they are recessing the inferior rectus, they are doing superior oblique posterior tenotomy on the same side. Also, other challenges on the inferior rectus when you are operating on tight muscle and if you recess more than 4 millimeter, the risk of lid retraction. And the most important one is consecutive hypertropia. When you are operating on tight muscle, use this guarded muscle hook to prevent you from the risk of scleral perforation. In order to limit the lower lid retraction, you have to try to expose and divide the lower lid retractors by using DeMaris instrument. What is the cause of the consecutive hypertropia? It may be due to scarring around the ligaments or overaction of ipsilateral antagonist or progression of the disease itself, or the inferior rectus is slipped. Some people, they prefer to avoid adjustment suture on the inferior rectus, and some, they prefer to use non-absorbable suture because they think if the suture is still there, the eye will not go up. How to avoid overcorrection? By careful preoperative assessment and force suction test in both eyes. Always think to relieve all forces in both eyes. This is a man of mystery who presented with a history of double vision for 2 years, secondary to thyroid orbitopathy, and had background of orbital treatment. His strabismus was stabilized for 6 months. This is the patient who has the marked limitation elevation of the left eye and large left hypotropia. What's going on in its eye movement? Is it because left eye inferior rectus tight? Or is there tightness of his ipsilateral antagonist? Or is there any kind of tightness in his contralateral inferior rectus? We decided to do just left eye inferior rectus recession, and we under adjustable suture, and he has this excellent result. In the primary position, he looks almost straight, and he is able to elevate his eye. But unfortunately, this doesn't last long. After months later, he developed consecutive left hypertropia. Why is that? It's because when we recess the inferior rectus muscle, he has tight inferior rectus contralateral eye, which makes the antagonist superior rectus of the right eye works hard to keep the eye in place. And as hearing low, the superior rectus will activate the left superior rectus and make it work hard as well, which end up with left hypertropia. How to avoid this? First of all, the force suction test prior to surgery on both eyes. If it's positive, you have to recess both inferior rectus muscle in both eyes. For the large hypotropia, consider opposite superior rectus recession. And always remember the fusional range for the vertical in such patient is huge. So they learn how to fuse the hypotropia image, but never fuse hypertropia image. So usually your aim of surgery is under correction. Never overcorrect such patients. What about if your patient has hypotropia and esotropia? Remember again, the inferior rectus is an adductor. So after you recess the inferior rectus, repeat the force suction again. If it's free, inferior rectus may be enough. Maybe the only muscle account for the esotropia. To adjust or not, remember your result of surgery is unpredictable in such cases, so having adjustable suture is helpful. If you are working on the medial rectus, always adjust. Regarding the vertical, superior, always adjust. Inferior, beware if you are recessing more than 6 millimeter. Volby, he wrote a paper about that, and he reported 54 patients with vertical strabismus surgery whose 60% of them require adjustment. In Jampolsky paper, he advised to avoid down gaze in early post-op period to avoid consecutive hypertrophy. So, a demanding area of strabismus surgery, and you need to understand the patient's and motility pattern, and you need to ensure stability prior to the surgery for 6 months, and you need to get careful pre-op counseling in order to get the patient understand what they're expecting from their surgery. Don't be aggressive with your surgery, and you need to do force reduction test for all patients, and be ready, available to discuss post-operative issue, because such patient quite reliable to have to need more than operation. This is just to show you how is the 25 prism can fit nicely as a Fresnel prism. So thyroid patients are unhappy because they have pain more than the others post-operatively, and they experience double vision more than others, and the cosmetic changes such as lower lid retraction or later problems like consecutive hypertrophy. It's good to remember the horizontal version is controlled by 2 muscles, but the vertical one controlled by 4 muscles. Sometimes the inferior rectus is unavoidable because in such patients. Thank you for your attention.
Thank you very much, Elham, for this nice and precise lecture. I will open the floor for questions. Anybody? Yes.
Okay. Thank you for your lecture. Very interesting. Just to bring some point of my experience with the Grace patients, and I do, of course, even Strabismus after decompression, and so I have some comments and of what you suggest. I agree, of course, to use the adjustable suture. And for the assessment of the patient, the preoperative assessment, I use the light reflex. We did a light reflex test is very useful, even it's only in the 4 direction. Because we did a paper on this with a group of the British Columbia with Peter Dolman and Jack Ruthman. And using this test, you can have an idea, a good idea of what is the preoperative plan, the operative plan. So if just you have the reflex on the limbus is 45 degree of movements, in limbus below the pupil edge is about among the 35 to 50, and in the pupil is below 50. So you can understand how you have to adjust the muscle. And speaking about the adjustable suture, the procedure, in my experience, it's very easy to avoid overcorrection. Just to, I do usually this operation in local anesthesia, so I can check the patient intraoperatively, and I adjust the suture intraoperatively, especially for the inferior rectus. It's very easy, and I see the patient after 4 or 5 hours, and if needed, I adjust a little bit with topical anesthesia. And of course, I try to not overcorrection, never. I just, sometimes I correct the strabismus a little bit hypo. So in my experience, even in vertical diplopia, you can get with a single operation 70 to 80% of success. So I think that it's important to adjust the suture intraoperatively, and try 2 or 3 times. So I did the first adjustment, and then I asked the patient to see at a point, and then I just, even while the patient is looking to that point, I adjust the suture, and you can easily get a good result. I think that there is no question, and I wonder what about how is useful the fourth test, because in all the Grace patient is a restriction strabismus. So I don't. I mean, in my hand, it's not very helpful. But I don't know what about your experience. Why is it so helpful for you this test?
It's important to do it to give you an idea how tight is the muscle. So we found it's very useful, especially in such patients, because all forces are fighting and all muscles fighting, and you don't know how exactly the extent of involvement, how much exactly, unless you are doing the force duction test.
Any other question?
Thank you for a very nice talk on a complex subject. My question to you is related to the upper lid. And being a glaucoma specialist, I've seen patients with thyroid ophthalmopathy, and we getting ready to do filtration surgery, and they have, of course, restriction, but they also have lid retraction. And we are worried as glaucoma specialists that the lid is retracted, and if you do filtration surgery, the conj is exposed, and of course the complications that arise from that. So my question is, if someone has restrictive thyroid ophthalmopathy and lid retraction, and if you were to operate on the lid and also on the relieve the ophthalmopathy, which would you operate first, and what would be the sequence of correcting muscle first, orbit first, or the lid first?
It's always we start by the strabismus first, then the lid.
Okay. I have a question to Dr. Qahtani as well. Do you recommend, the force duction test is not that helpful, do you recommend bilateral inferior rectus recession anyway, or you just go for unilateral and see?
In our experience, most of the patients who are undergoing for unilateral inferior rectus alone, and they presented with huge hypotropia, they will have consecutive hypertropia. So it's good to avoid this by either to do bilateral recession of their inferior rectus or by doing contralateral superior rectus.
At the same setting?
On the same setting, yes.
Yeah, I agree. And I did bilateral cases only when there is a very, very difficult life for the patient with the chin up. So in that case, so the bilaterally the inferior rectus muscle is involved. So only in those cases I did bilateral recession of the inferior rectus. But it's very limited. I mean, I agree that you should be careful. If there is a difference, you have to start with the worst eye, and then see if there is the needs of a further surgery.
There is, of course, a known condition which is called progressive inferior rectus recession. So if we do recession, most likely the recession will continue. Is there any way to avoid this?
What do you mean that we're going to continue?
For example...
do you mean it will going to creep back?
Yes. How do you avoid that the recessed muscle probably will...
This is like Jampolsky paper. He advised to avoid down gaze position immediately after surgery. Sometimes they put like a patch on their down gaze and the lower part of their glasses, so to avoid them from looking down.
I mean intraoperatively. That's the use of absorbable, non-absorbable.
I use absorbable intraoperatively. And in my experience, what happened is that instead of get a worsening of the, not in, I agree, because there is a little bit of worsening with over time of restriction because of the fibrosis of the conjunctiva and tenon. Because in Grace patients, of course, they have, even if the inflammatory phase is over, when you operate those kind of patients, and you open again the conjunctival and tendon, of course, to reach the muscle, after 1 or 2 months, there's such kind of fibrotic process that can get some loss of the results. Yeah, so you are right, but there is no way to avoid this. I mean, theoretically, you can give some steroids, in order to prevent the fibrosis process. But I don't know actually it works. But I agree, it's possible, especially in Grace patients, to lose some result because of the fibrosis process.
In our study, we used observable suture for the adjustment, and all our cases was under adjustable sutures. As long as you are avoiding large recession by doing the contralateral eye, I think it's fine to use it.
What is the maximum recession?
It's less than 6.
Is there any other question?
Actually, if I have one more. Thank you again for a wonderful presentation. This is perhaps straying a little bit away from strabismus, but for Graves' orbit disease in general. What is the current thinking about treating the inflammatory phase? If you could educate those of us that are a little out of touch on the use of irradiation, steroids, anti-inflammatory and immune suppressing, such as rituximab, what is the state of the art on that?
It's, of course, you have to wait until the patient's strabismus is stabilized, and never treat the patient in his acute phase or during his reaction. They have to be stable and the disease itself is quiet. Then you think about the strabismus and solve it.
But Don, I think that your question is about the treatment. Yeah, for do a short review is under discussion, still under discussion. I mean, in the last board of the ITEDS, it's International Society of Thyroid Disease, we discussed about new protocols to compare the steroids, intravenous steroids, and radiotherapy, especially for optic crowded, for the apical crowded syndrome. I mean, now, in general, you should start with the intravenous steroids for the acute phase, for the inflammatory phase. You evaluate the patient with using the clinical activity score. If the clinical activity score in grade 0.7 is more than 4, you have to start with the steroids. And basically, it's suggested to start with the intravenous steroids because prevent some side effects that you can get from oral steroids. Intravenous steroids, in my hands, I use 10 milligrams per kilo twice a week for 6 weeks. If this doesn't work, you can use alternately radiotherapy if the patient is older than 40 years, and especially if the patient has a vertical diplopia. And then you can use alternative treatment as methotrexate. We did a paper on that, or you can use the new infliximab or rituximab.
Comment related to, again, going away a little bit from the topic, is the elevated intraocular pressure when the patient's looking up. And, we're often as glaucoma specialists asked, is this elevated pressure is something to be treated or not? And the short answer is no. These patients do not develop glaucoma. And I have seen 3 unfortunate cases in my career where these patients had sort of tight orbits, they didn't get proptosis. Their pressures were high in the 20s, and they were losing visual field and vision. And the bottom line was these patients had, thyroid orbitopathy causing compressive optic neuropathy. But the patients came with 4 glaucoma medications trying to treat that. And so one needs to be aware that the optic nerve, and this is for the residents and fellows, that it's more likely that your patient, if they're having visual symptoms, is due to the optic nerve and not due to glaucoma. And so the high pressure is not, you don't worry about the high pressure. Look at the optic nerve and look at the imaging.
Thank you, Doctor.
Thanks, Doctora. Two questions. Since you did like a large study about 188 patients, my concern is the close relationship of the inferior to the lower lid retractors, as you mentioned that clearly. From your experience, whether in the study or from your readings, what's the percentage of developing a lower lid retraction in such patients after strabismus surgery, especially in inferior rectus? And since we're talking about the pitfalls, what do you think, or what's the advice for the strabismologist to avoid such a complication?
It's very common to have lower lid retraction if you are doing large recession of the inferior rectus. So the advice to either reduce this recession or to use DMARS and expose and divide all the inferior rectus fibers, so to decrease the chance of having lower lid retraction.
My experience is about 50%. And you can start with the body agreed to dissect the retractors in order to avoid the lower lid retraction. But it prevents in very few cases. What I do now is to dissect the retractors and put a frost suture, to rise up the lid for 24 hours or 2 days, and in some cases can work.
What about the association of thyroid eye-related disease and myasthenia gravis? Did you see any one of your patients?
There is some patients they have both together, and in our study we excluded such patients. We make it only purely for the thyroid patients, but it's about 20% myasthenia can come with thyroid patients.
Yeah, so those who are having thyroid eye-related disease, they can have myasthenia gravis.
Yes, and
just to make it clear.
and you have to rule it out before.
I think the percentage is less than this.
I would say 5 to 10%. And the typical clinical sign that you find is that one eye has retraction and the other eye has ptosis.
Yes.
So this is the typical sign that can suggest you to rule out the myasthenia.
Or if the patient have exotropia, for example.
Exotropia, yeah. But ptosis on the controlled eyes is strongly suspect for the myasthenia, association with myasthenia.
Any question? If there is no questions, we can conclude. Thank you very much, Dr. Elham.
Thank you.
And thank you for your time.